Good afternoon, everyone, and welcome to the Recovery Support Services ECHO series. This is a training brought to you by the Center for Substance Use Training and Telementoring, CSTAT, a division of the Be Well Institute here at UT Health San Antonio. My name is Andrea, and I will be helping to facilitate this conversation. But before we start, I have a few quick announcements to make. Please remember that this session is being recorded for later distribution, and you may find it later at our Be Well Texas YouTube page. In the meantime, please continue adding your names, email addresses, and affiliations to the chat. We will use this information to confirm your attendance to this class. If you're part of our provider network here at Be Well Texas or you're seeking CEUs today, even more important for us to know that you were here. So if you're joining via phone, please send us an email at cstat@utesca.edu so we can associate your phone numbers with your names. And today we have a didactic presentation by Dr. Carma Deem Bolton. We want to welcome Dr. Bolton to this session. Welcome to the RSS ECHO. And after her presentation, we're going to be opening the floor for your questions and conversation. And then after that, as usual, we will have someone discussing a brief case. This is your opportunity to participate and express your perspectives, especially during this part of the session while we're discussing the case. And it's going to be Brett Foster who's going to be discussing this case. So welcome as well. We're going to start with some introductions from the RSS Hub, but first I want to welcome a new Hub member here at the RSS ECHO series. Welcome, Kimberly Govak. Thank you for joining us. We're very excited. And if you could briefly introduce yourself to the team, that would be great.
Sure. Thank you for the opportunity, Andrea. Hi, everyone. My name is Kim Govak. I am in South Jersey. It's wonderful to be with you all. I am a woman in sustained recovery management. I was the program director here in New Jersey for a regional recovery support center for a long time. And most recently, I was at Faces and Voices of Recovery, where I was able to work with some organizations that were going through accreditation. So I have been able to visit a couple of recovery community organizations that are listed here. So I see some folks from some places in Texas that I've been able to visit and see the great work going on there. I'm currently a facilitator at Rowan College of South Jersey for Certified Peer Recovery Support Specialist. So I'm really happy to be here and to meet all of you. Thank you.
Thank you for joining us, and again, welcome. Richard Hamner, would you introduce yourself briefly to the group, please?
Sure. Hi, Richard Hamner with Be Well Texas, Recovery Support Services, Hub member, personal long-term recovery. Glad to be here today.
Thank you, Richard. And Susie.
Hello, everyone. My name is Susie Walker. I am a woman in long-term recovery, and I am the executive director for the Recovery Partners in Vermont. And I've been in the peer recovery world. I was a director of a recovery center here for 14 years and was also lucky enough to join Faces and Voices of Recovery for a while. And it's just a pleasure to be here with you all. Thank you.
Thank you, Susie. Brett, would you introduce yourself briefly, please?
Yes. Hello, my name is Brett Foster. I'm a person in long-term recovery. What that means for me is I haven't any alcohol or drugs, or any other drugs since January 11th, 2009. And for that, I'm truly grateful. And I've been a legacy coach with Detcata, who's a legacy program of recovery here, for about 11 years. So looking forward to presenting the case. Thank you.
Thank you for joining us. And I think with that, we can start sharing the PowerPoint presentations. And again, Dr. Bolton, thank you for joining us and for being with us. And whenever you're ready, we can take it away.
Okay, thank you very much. I'm glad to be here today. Let me go ahead and start screen sharing. All right. So today I want to talk a little bit about compliance to impact. So how to really leverage data collection to support recovery support services. I have no additional disclosures are in here. The views and opinions expressed are my own, not official position or policy of UT Health San Antonio. So the learning objectives that I want to touch on today is how to develop data collection strategies to meet grant requirements, but also to align with organizational goals. Discuss a little bit about tools and techniques that can support effectively managing that process and analyzing data, and then how to effectively use and leverage that data to support recovery outcomes at organizations and also be able to effectively communicate program impact. So when we think about data, we have a new grant coming in. I think a lot of our heads go to, oh, we have to collect this data for compliance. We need it because the grant is telling us that we have to submit it as part of our requirements. What I ask is to think beyond that. Any data that's collected has potential. That data that you're submitting for compliance to a grant or a funder, rather, could also be leveraged to support service delivery, to improve outcomes. It could also be used later to support future funding opportunities and promote sustainability of services. So data is not just for compliance, it's really a tool for improvement, not just reporting. So I'm going to transition into talking about how we're going to set a data infrastructure that promotes these things. An important component when setting up a data strategy is really having someone who takes that lead on the data. Assigning a data lead doesn't have to be in title, but just an individual who's an expert on that documentation and how it's captured, knows the definitions and where it's coming from. Someone who can ensure that the data is valid. Data entry errors happen all the time, and having an individual whose primary responsibility is to reconcile discrepancies in the data is very important for reporting accurately. That they ensure the data submission timelines are met, and who can facilitate internal communications surrounding data. An important point I want to bring up is that having one person to serve as a data lead and the only person that knows these ins and outs is really not ideal. So coming up with a secondary person who's also familiar with these processes, definitions, is very important. I don't know if any of you have a similar experience that I had in the past where you've inherited an Excel spreadsheet that has your program's data on it. And it has data, and it has cases, and it has the data points. But then you start questioning, where did this come from? What was the definition of the client who makes it onto this spreadsheet? And you do not have a trail because the prior person has moved on from that position in whatever capacity to another. And so it puts your organization at risk for really having to start over because you're unsure of the definitions and you want to be able to report accurate numbers. So having that backup data lead is super important for data governance and to ensure consistency in data collection. So as we start to think about collecting data for one or multiple grant requirements, starting with a structure is imperative. One way to do this and ensure that that structure is solid is creating a data protocol or a data plan. The first component of that is really understanding those performance measures. What is the definition? How is it operationally defined? If it's a metric where you have a denominator and a numerator, making sure that those requirements are clear and you're collecting the correct data is really going to support the utilization of that data later on. Disseminate these measures when they come in, discuss them with staff that might be involved in the data collection, put a why behind it, create that buy-in, work with staff to look at what the appropriate way is to collect that data. Your frontline staff are the ones that often are compiling it or entering data within their workflows, and knowing those workflows is going to increase the validity of your data and the impact. When you have new grants coming in with performance measures, scan what you're doing currently. We don't want to do duplication of efforts or accidentally not understand a workflow and have two data collection points for the same thing. So being able to scan what the organization is currently reporting out can really decrease time and effort when it comes to data collection. Also, when you're looking at different reporting measures that come in, think about your internal quality improvement initiatives. Is this something that you can combine with a low burden, 1 or 2 additional measures that you can then leverage for quality improvement internally, and then incorporate that? So let's talk a little bit about data protocols, or excuse me, a data plan. So there are a couple different ways to do this, but one example that I have here that I wanted to bring to the group, it was just using an Excel spreadsheet, which oftentimes is the one thing that organizations have without having to buy additional licenses or acquire new software. So the point of the data collection plan is to really put down in writing the performance measures, how they're operationalized, who's collecting them, how they're being collected, where they're being collected from. So this will really help keep a trail, keep visibility into how these measures are being collected in the organization. Additionally, it can, if you have a performance measure that you're not currently collecting and you need to create a different workflow, this information can help you define and create that data collection instrument. So in the example here, we have grant A that is Cayman. The first performance measure will be transportation services. What aspect of transportation services are we collecting? Well, the specific grant wants the number of transportation services, so reporting just a number. Okay, let's find out where we're collecting that if we are currently, or develop a new data collection instrument in order to capture that information. Then enter that in the data source and location so we know exactly where it's coming from. Who's responsible for collecting this data and at what frequency? And then how, the details of how it will be collected and how it will be used. Thinking about transportation services and what I mentioned earlier about looking internally, like, is there an opportunity to combine this with 1 or 2 measures to create information on something that we're interested in internally? So instead of just the number of transportation services, we'll say this organization that I'm using in my example really wants to know, of those transportation services we provide, which ones are being distributed the most? Is it bus passes? Is it a Uber or Lyft voucher? And as you see in the last column to the right, add those additional data elements that you're collecting to it so you know when you go to do the instrument or include measures that those should be included and you can leverage it for QI. So this is really going to improve or serve as the base rather for the consistency in data, transparency of that data collection. Also ensure that it's aligned with the definition, and it can serve as a reference for specific grants on how data is being collected, which is important to leverage in discussions surrounding data collection and reporting. So let's say in transportation services, we need to generate a new form to collect this information. Use that data collection plan in order to design your columns, in order to outline your data collection instrument and streamline it, optimize what you're doing. Those data variables that you collect in your instrument, if it's a new instrument, should mirror what you've said in the plan that you're going to collect. So here, for example, transportation, it's an additional tab in an Excel spreadsheet to the protocol. So it's easy to reference the protocol to the data being collected. And we put the basic information, date, client ID, name. Then we add our QI measures that we've come up with, type of transportation and purpose. And then we have a tally of the quantity, which supports our compliance or our funder requirement of what they want to see. When you set up new data collection instruments, or for that matter, even are incorporating into an existing workflow, always look for opportunities to set up that solid base to minimize effort that you need to put out later when compiling data. So if you notice to the right of this screen, in Excel, you can embed pivot tables and connect it to the data right beside it. That way, it automatically tallies when new data is entered into the spreadsheet, and you have a very quick view and readily available view of how many bus passes, for instance, we gave out on 416 and 417. It totals on 3. And you can break it down by date if you'd like. You can create those pivot tables and customize them to your needs. So then later, you're not having to manage the full data and create these pivot tables or create formulas to slide in different measures to get a count. Just one thing about pivot tables, I think the main thing to keep visible is to make sure your range of your spreadsheet that you're telling it to look at is always updated as far as your data goes in the spreadsheet. But this will ensure data collection alignment, and thinking through and adding in any opportunity for including aggregation of the data, such as in the pivot tables, will speed up processes later on, especially at busy times when we're reporting out. So let's talk a little bit about multiple grants. So it can be overwhelming. Some grants will have overlapping in measures. Some are standalone measures. Having a centralized repository or a master data collection sheet can bring visibility to what your organization is reporting out on multiple grants. There's some real benefits to having a global view of what's going out. It makes it easier to assess when new grants come in, are we already collecting this? And if we're already collecting it, does the definition of how we're collecting it match this new grant opportunity? If it does, we know that we can just leverage that existing measure and the data from it for that grant. And we can continue to evaluate additional measures to see if they need to be added or if they're already something that we're collecting. This really supports data governance. Things can be documented in multiple places, as I mentioned before, within electronic health records, within the organization, and being able to have a standardization of what is the source of truth is really important. So let's take, for example, again, the first column. We have our performance measure. We'll say transportation services again. Continue that operational definition so there's consistent visibility in that and where it's being collected from. Additional columns can vary in content depending on your organizational needs. One of the main things or changes that you'll notice is to the right, this organization has 3 grants. Grant A came in first, and it required the reporting of transportation services. So I denote that in that column and denote the reporting date. But what you put, again, in these columns is specific to what information you need to reference. When Grant B came in, we didn't need transportation services to be counted for Grant B. But then we had Grant C come in, and they also required the number of transportation services. And after cross-referencing the operational definitions, we know that this same performance measure can be plugged into Grant C. Same thing with housing referrals on the next line. Housing referrals came in on Grant B. So that's when it's added to the spreadsheet. So we have this overall view of, on the line, the performance measure, we'll say for housing, Grant B and Grant C are reporting that same measure. And transportation services, Grant A and C are. An additional pro for having this list is that you can also apply filters to that title line, and you can filter all the requirements that you're seeing on Grant A to yes and see all of those measures. Or look at performance measures and do a search to see if you're already collecting them instead of scrolling. So again, this really supports data governance and consistency in what's reporting out from organizations. So you're not reporting out unbeknowingly two different numbers for the same performance measure and then having to later track down the discrepancy and reconcile, and helps avoid that dynamic. So these examples that I presented have been just in basic Excel, but there's a lot of other opportunities to create data collection strategies. So I encourage organizations, if you can and leverage technology, do it so it can save time. Spending that time up front to create that solid data infrastructure can support efficiency long term. And looking at and knowing what tools are available for the job will also decrease that burden. For example, larger organizations or organizations that have more going on may want to look into Microsoft Access to organize their data collection and management. You can do a lot of things in Access. There's a lot of online, free available YouTube trainings for Access as well, in which you can have an interface like to the right for data entry, and then you can hop to a screen like the one on the left, where you can enter your data and you can see that in the spreadsheet. When it comes to other types of data collection, tools like Microsoft Forms. I made one right here a couple days ago for a transportation voucher log that would be forward-facing to the staff that provides it, where they can quickly enter in a structured way the information is needed and submit it, and it automatically stores in an Excel spreadsheet on the back end is another option. Excel also has the ability with their form functions to create the same kind of interface that you see on the left in Forms in an Excel document and then stores it in a spreadsheet. Doing things like that can also improve your data entry, reduce errors in your data as well, and they're readily accessible programs. When it comes to automating reporting, pivot tables are great to set up in the beginning in Excel. In Microsoft Access, you can create custom reports that can generate data like you see on the right here in whatever format that you need. So now that we have our data plan, we have our data tools and technology set, we have our reporting for our grants to our funder. That type of reporting is typically just to communicate the information, to demonstrate that we are on track. An example of that might be 25% of individuals enrolled in long-term coaching were employed at enrollment. And that satisfied the compliance component of the funder. However, think about that when the data is coming in. Okay, we're collecting this information. How can we use that information with minimal added effort to assess value or effectiveness of what we're doing to support individuals achieve employment status, employment? These things can be incorporated to then turn it into a QI measure. For instance, if they're assessed at intake for employment, and then you decide at 12 months to assess again, then you can create statements and provide evidence like the example. Employment status of individuals in long-term coaching increased from 25% at enrollment to 80% at 12-month follow-up. And that's an impactful statement that you can make about how your services are helping clients on their journey through recovery. And then that can be leveraged in multiple formats, whether it be for future grant funding opportunities or community facing. So the key in keeping in mind when grant requirements come in and what internal QI or potential QI that your organizations are running is, how do we eventually turn this data into action? You can do that in multiple ways depending on what your organization's needs are. It can be used to set benchmarks. It can be used if you have that longitudinal reporting data to assess for trends and outliers. For instance, on the left, just that variable of transportation where we're providing counts. If you track that over time, which you're entering in monthly, we'll say, you might be able to see some type of trend or some type of anomaly in the data that sparks a conversation that can lead to QI. For instance, what happened in March? We skyrocketed to 72 passes that were handed out, but then we had a dramatic dip in April. Is there something that happens during this time that we may need to take in consideration to be more prepared for that spike? Is this just a one-time thing? Is this something that needs to be on our radar when we're thinking about how many passes the organization has and allots over time? It can be leveraged in that way. It's also really important to share data back to teams. Teams enter data, and oftentimes they don't see that data back. So it becomes just a burden, something that I have to do for my job. But increasing that staff buy-in, feeding information back can further support ideas and exchange of information and help staff understand the why. Some other examples of how you leverage that type of data and turn it into action. I love this one on the left. These are just basic numbers that could be pulled from reporting requirements that provides a community-facing infographic to highlight the organization's capabilities and successes. On the right, we see that employment outcome chart. If you're doing reassessments, you can do pre-program status versus post-program status and show the change in whatever measure you're looking for by just an added assessment within a workflow that is already tied to a compliance measure or reporting measure. And that can be leveraged and really powerful when you're thinking about obtaining new grants to show that not only did we serve this many people, we were able to increase this employment status over their life in the program effectively and by a large amount. So think about those visuals in that use. So the key when doing all of this is start with a plan. The plan is super important. It is a staple of data governance, consistency, transparency. Use the right tools. Think about what you have available to you. Think about what trainings you might be able to attend that take a moderate amount or a minimal amount of time that can improve your data collection strategy. And then think about when you're doing that plan and that data setup, how can we turn this information into meaningful insights to support our organization, not just in the current grant that we're in, but in our QI processes to improve patient outcomes or client outcomes, and to also be able to leverage for other opportunities for grant funding and community engagement. I've got some good references on different types of data collection in the PowerPoint. And with that, I will close. Thank you very much for having me, and I'll turn it back over to you, Andrea.
Thank you, Dr. Deem. This was really enlightening and to the point information. One very important, clear item here is how data informs evaluation, although sometimes we tend to put them together, or we kind of confuse the two of those, how data informs evaluation. Great presentation. I'm going to open it to the floor now to see if our participants have questions or comments.
I'll chime in briefly. Susie here. And I was thinking about when I first got excited about data when I was a recovery center director and how it helped the staff understand that data helps us tell our story. And so that when they got to see, the fact sheets, when they got to see the results of the data collection, then it became more valuable to them. And they understood the reasons why, and that it could help you measure your success, and it could help you, maybe change your course. If things aren't going as you anticipated, you can use the data to help guide you. And it made such a difference when we made them a part of the process of storytelling, not only the collection, which at first is like, oh, we have to collect this stuff. But when they saw the power of it, it was pretty amazing. And when you get to put it together in like an annual report or something, that's so powerful to see. This is the impact of what you all do every day. That's all. Thank you.
Thanks, Susie. I was going to add something too, because I think, Dr. Bolton, thank you so much for going through this. It's just really, it does bring this thing kind of a, that mundane task of having to record all of this information. Sometimes, yeah, we lose the picture of what it's for. But I also wanted to say too, I loved your spreadsheets, and I loved that the way that that's all laid out. And I know that sometimes an individual can become a little overwhelmed with the Excel process or maybe Access or some of those things. So I thought it was great when you pointed out Google and YouTube are wonderful tools for kind of walking you through those processes. And I know a lot of times, even for me, it's use it or lose it. It's like I may have used some of those Excel tools in the past, and it's like, oh no, and then I have to go back. And so I just kind of want to bring that up in case anyone else maybe had those same concerns or worries. But God, what a great tool it is, and it's so nice to be able to have it. So thank you so much for that.
Yeah, of course. And I think you bring up a good point, Richard, the use it or lose it part of it. And I remember in my prior life inheriting a program's data, and I had not done Excel, or I'm sorry, Access in years. We've got multiple people entering data. I'm like, oh my gosh, how are we going to do this? And I took the time and I went on YouTube and I just watched videos. And it takes some trial and error when you're learning it. But ultimately, what we came out with as an end product was super efficient. And the navigator that was working with that program was easily able to maintain that data consistency. But yeah, absolutely. I reviewed and reviewed, but it did pay off in the end, taking that time up front.
Yeah, no, that's great.
Any comments related to your experiences with data? I know many of us prepare reports and collect and organize data monthly. Any of you, would you like to share any experiences with that? And if not, that's okay. We may come back to this presentation again. In the meantime, in the interest of time, we're going to share some brief announcements, and then we may come back to the presentation and as we discuss our case today. The Center for Substance Use Training and Telementoring, CSTAT, offers technical assistance for different substance use disorder needs that you or your organization may have. This is a free service to all of you in the community if you are in the need of any type of support related to substance use disorders. Please go to our page and complete the TA form. After that, someone from our team will contact you in 2 or 3 days. Next. And to claim your CEU credits today, remember you have to complete the post-session survey. You cannot retrieve your CEU credits or receive your certificates if you do not complete that survey, because it's in that question that you see there on the screen that we will know if you're interested in receiving a certificate after the class. So please remember to complete the survey. We're sharing it with you on the chat, and we will send it also via email along with the materials that we are presenting today. Next. And this is going to be our second session of the series Maternal Health Echo. We invite all of you to attend this great series. Our first session was a total success. This is directed to healthcare professionals who want to help pregnant or postpartum women who use substances. That is Tuesday, May 6th. And again, we're sharing the link with all of you. We'll see you there. Next. And we're excited to announce our Texas session. It's going to be novel approaches to crafting hospitals' blueprint for addiction care. We're going to have Dr. Ramesh, Dr. Freeland, Alana Bolton, and Maria Escamilla. Please don't miss it. We're sharing the link with you. It's a great session, and of course, credits are going to be distributed. We'll see you there again. Friday, May 9th. Thank you. Next. And of course, next month, we're going to have our next session of Recovery Support Services Echo in the same space. Thank you. And now I think that we are ready to start sharing our case form. And Brett, if you could briefly walk us through your main challenges with this case. Thank you.
Okay, thank you, Andrea. Yeah, so as you can see, this participant's kind of been in and out of connection for about a year with our program. Some of the other recovery coaches have had the opportunity to, work with this person, you know, for a time, and me more recently, kind of taking him on personally, and he's been on buprenorphine, naloxone for about 10 years, and he was prescribed that medication for pain management. At least that's what he told me, and but he's really feels like that he is basically tired of taking the medication. It feels like it dictates some of his life and some of the choices that he has to make that revolve around the medication or taking it or whatnot. And he would rather live more independently than what he has been, basically as part of his recovery capital. You say he's basically sleeping on the couch or whatnot with a friend, and has been doing so for I think about a year and a half. So, but yeah, so he doesn't have legal transportation, but he was left a truck from his loved one who passed, and it's not legalized. Still needs to get it put in his name, and um, yeah, so he can't get a driver's license and legalize his truck until he takes care of some legal situation in another state. But he's probably going to have to turn himself in and do a little bit of time there. But he's really nervous about going there and turning himself in because he fears that he won't be able to take his medication, which kind of leads into some of the questions that I have, and that's, what are some possible options he can talk with his doctor about? He brought that up that he wanted to maybe look at some different options, and then um, I, if anyone has any experience with maybe helping someone or assisting, providing transportation, providing recovery support with someone who's transitioned from freedom to turning themselves in, and how that worked as far as whether or not they were able to immediately start taking their medication, or if, has there been anybody experienced where a jail said, no, you're not taking that while you're here, or any of that, because he has a lot of fear and anxiety around that, which is really holding him back from progressing in his recovery journey. And work and things like that. He has to have transportation, especially from where he lives. He doesn't live in the city where a bus route would go. And yeah, and there's any other strategies or resources that you guys could think of that I might could try that would help him progress.
Thank you.
Thank you, Brett. I think in your presentation just now, you answered one of the questions I had, which was that if the substance use started for a pain management reason, is pain management still an issue that needs to be dealt with in some way? Or is that just something that happened years ago that it doesn't sound as if from your presentation that he's concerned about how do I manage my pain without this medication? Is that the case?
That's a good question. I mean, he does say that he needs something for the pain, but
Mhm.
I don't know that he's actually had to go without his medication for long enough to
Yeah.
actually know whether or not he really needs it. But he does describe having a lot of pain and anxiety and medical symptoms presenting when he runs low, or if he runs out for a short period of time before he can get his refill, and it's not good. So
Thank you. And then I also just thought, because I was a recovery center director, I saw some of our participants and our staff too decide that they were ready to make a change in that area. And, the importance of role clarity came up in my mind, that you want to consult the medical team about the medical questions. And there are people with lived experience in the peer recovery world, coaches and other peers who perhaps have that very experience, but you can be vulnerable with your peer support person, and you can go for more concrete details about the medical aspects of the change you want to make with your medical team. And then for the piece with the correction system, that can be so different in so many places, even within a particular state. So that would be a matter of maybe connecting with if there are reentry teams, if there are people in probation and parole or other departments who just might have that information to be able to say, it says in the case that he's scared to death, literally, about the prospect of having to go and do without his medicine. So maybe that fact gathering can help alleviate his concerns too.
Yeah, and to the point specifically about the medication, Susie, we have Dr. King here.
Oh,
Dr.
great.
King, would you like to give us some ideas in this case? I think you're muted. You're
Can you hear me
muted.
now?
Yeah, I can hear
Okay.
you now.
All right.
Thank you. Hello.
Hi, everybody. Yeah, this can be a very difficult thing. I agree with Ms. Walker that it's hard to know how they're going to handle him if he turns himself into any given place, if they're going to put him in a jail. Some jails will give people buprenorphine, but it's not very many. And depending on where he goes, they could very well just, incarcerate him, and he's going to be there as long as he's going to be there. Um, it may be that you could find out, or he could selectively go someplace where they might, give him prescribed medications. But it would, I think it's more likely if he goes to a large city or some place that has a more sort of progressive attitude towards substance use treatment and things like that. So we really don't know. Do we know which state he's got to go back to?
I believe it's Mississippi. I'm
Yeah.
pretty sure. Mhm.
Well, anything's possible, but I wouldn't cross my fingers on that one. So and do you know how much buprenorphine he's on?
No, yeah, I don't know anything about the amount. I just, but I know that, you know, eh, I wasn't gonna, suggest any, particular medication. I know we're not stepping outside of our lane, of course, but I was just kind of wondering, like, are there other medications that would maybe do the same thing that he needs, but not be as problematic? I don't know.
Buprenorphine is a milder kind of medicine than, like, let's say, methadone or fentanyl or heroin, but you're definitely going to have some withdrawal if you stop it abruptly. And the higher the dose you're on, the more withdrawal you're going to have. Unless he's very ill, has chronic illnesses that might, make him vulnerable. He's only 40 years old, so he's relatively young. It would be highly unlikely to die of withdrawal. People go through it all the time, and it's milder with Suboxone than with methadone or some of these other ones. But it's going to go on for a while. And I know people can sort of find themselves in a bit of a pickle and worry about, how they're going to be feeling. And, it's understandable. Yeah, I don't, if he, does he have, medical insurance funding? Do you know?
Yes, he does have a form of medical insurance, and that's helping with payment of some of his medication. Some of it he has to, uh, you know, come up with the rest of the money
I
for it.
see.
But he is a part of a program, a local uh, program, Suboxone program that another agency has that kind of monitors and has some different things and stuff. And so he is on a he is seeing medical help for the situation. But I don't believe he's ever brought up. My opinion is that he hasn't brought this subject up to his doctor or medical team about the problems that he sees with it.
Right, right. Well, I think that's the first order of business. But if he's been on this for 10 years, he can't just easily taper off. And I agree with Ms. Walker about, if he's got chronic pain, then all of a sudden he's going to have a lot of pain to deal with too. It's going to be very difficult for him. Um, Now, one thought I did have is if he thinks he's going to have to be there for, a matter of days and not months, if his program has Sublocade, which is the injectable form of Suboxone, it lasts a month. So if they had that available, it's like costs about $1,500 or something like that. So it'll depend on whether they have nurses and capacity to do that. But it'd be definitely worthwhile asking, because that might really be enough to sort of get him on the other side of an incarceration, and then he wouldn't have that that discomfort to go through.
Mm.
But
That,
from what you're saying, I mean, it doesn't sound like he's using opiates. I don't know if he's having problems with other substances at this point, but yeah, you're right. He's sort of stuck in his recovery, sleeping on somebody's couch. He can't, he's not working. I mean, he needs to do something to move forward. I agree. Um, but I
yeah,
think,
thank
at least from my point of view, and he should talk to his doctor. But in fact, you can take 2 or 3 days worth of Suboxone if you're just going to be in jail, a weekend or something like that. That's one way to prevent withdrawal as well. But as you pointed out, he's got to do it with his doctor's advice, and um, he's going to be more likely to be successful that way. But I think that, yeah, and plus he's going to have to talk to him, because if he wants to come off Suboxone, he needs to think about, well, what's a reasonable chronic pain kind of medicine to take, and whether that would be available to him. Because if he needs an opiate of some sort, it's very few people are going to be willing to give him something besides Suboxone. If he's had a substance, an opiate use disorder in the past. So he's going to have limited choices there.
Well,
thank you.
thank you. Thank you,
Yeah.
Brent. Thank you, Dr. King. We'll go back to you, Dr. King. There is a comment on the chat from Patricia. Would you like to unmute and explain a little bit about your comment? Yes, Patricia says, I hear two things. He wants to be off the meds because it controls his life, but he's scared to go to jail because he won't be able to keep taking meds. Brad, could you elaborate a little bit more on that?
Yeah, I mean, it is kind of it is kind of a catch-22.
Contradiction.
Yes, I mean, he wants to take care of this issue so he can get over that hurdle, but he's really nervous and scared about experiencing the withdrawal symptoms. I mean, even though, we've talked about, that according to the training that I've had and the others have had, that like the doctor said, it's highly unlikely that someone would actually pass away from the detox, but it would definitely be very uncomfortable. And yeah, it's just kind of like he's in that, like, I want to do something, but I can't do something. So it's kind of like he needs something to say, okay, this might be something that I could try. And I have not heard about, or at least in a while, about that injectable idea, and whether that would be an option that, he might could discuss with his doctor. If he, like the doctor said, if he's not going to be in there for a long period of time, that might be a solution. So yeah, that might give me some hope on that.
Anyone else in the group who has any experience with similar situations, medications in jail,
I was going to jump in there
alternatives?
real quick.
Yes.
And I just, first of all, Dr. King, thank you so much for jumping on last minute. And I
Sure.
think one of the Brett's questions I think you really addressed is just like, what questions does he have for his doctor? What kind of conversation what should that look like? And so I thought that was extremely helpful. Um, yeah, and if there was any way of finding out like where he's going, I think Brett earlier in the conversation had said he's been in contact with either the court or someone where maybe Mississippi, wherever that is. If he could get maybe a little more information on what that detainment might look like, and maybe that would give him some ideas on how he can best medicate for that.
I mean, oftentimes they're very reluctant to give people any kind of controlled substances or things like that in jails. That's usually the big issue. But some jails do allow you to bring your own medicines and to use it. So if he could find out exactly, what he's up against, at least he'll know for sure. It'll help him to plan.
Yeah, that's a great idea. I mean, because like I say, talking to the court or the court clerk is not the same thing as actually talking to the jail that he would be going to. Yeah, maybe he could contact the jail and just see if they have a policy they'd be willing to tell him about concerning those medications. That's a great suggestion. Yeah, thanks, Richard. Thanks, Dr. King.
Amy,
I
did you want to say something? Amy Vigorial?
Yes, I think that there's an infirmary in most jails, and if he does go through withdrawals, in the intake process that they're going through when he's being processed. I don't know the right word. They do ask about medical and if he's taking any medication. So he can take his medication in there. And if he does start going through withdrawals because he's not taking the meds as he takes them, then, there should be an infirmary in there to help him through that. If it's prescribed, they shouldn't stop him from taking it, depending on how long he's going to be in there. And they should watch him. I know I've had several friends and family go through that process and they've taken their meds in there. It's only on certain cases that they weren't allowed to take the meds, but if they went through withdrawals, the infirmary did help them through that. And they do have nurses and doctors in there to help them with whatever it is that's going on with them, or they send somebody over there to help them through whatever medical issues that they're going through. So it's how long is he going to be in there for? If it's really prescribed to him, then he needs to take those bottles with him. And is he that dependent on it that that's what is he more scared of? He's not going to have it in time. Is he overusing it? Like it's not as prescribed. So that's what's scaring him. He's taking it more than what he needs to. But I mean, in every jail or prison setting, there's usually an infirmary, and they can help him if he's going through withdrawals or with the time that he needs to take his medication. Maybe that'll help ease his tension with that.
Yeah, thank you for that. Yeah, those are definitely some things to consider. And again, when the conversation earlier I had that, in my experience with dealing with peers, it's a wide range of, some they say, oh, you go in, that's no problem. It's that they didn't experience a problem with it. And then some they say, no, that's not allowed. You're not going to have it, and you're just going to have to, suffer through it. And they say, well, they can try to contact that medical team, and but whether or not they have one that actually responds quickly to things like that, or whether they just like, well, you're just gonna have to go through it, and they're not going to give you anything to maybe help or
Right.
whatever. So I guess
Yeah.
it's probably just a wide
Yeah.
range of just where you're going, what their policies
Yeah, it's
are.
sort of unpredictable. So, if you can sort of nail something down just by talking to folks, that would be the best. I saw we have a couple other chats here. So,
Yes.
so Vivitrol is a blocker, and it would actually cause him to go into withdrawal if he took that. So that's helpful for people that are off of opiates and want to stay drug free, but you would have to be off of the buprenorphine probably a good month to take Vivitrol.
Mm.
And
Yeah, thank you for clarifying that, Dr. King. And then Cheryl Ledford, you had a comment. Would you like to unmute and tell us and share your comment with us? Cheryl Ledford.
Yes, so I just was sharing that I have a client who or a peer who is using a MAP program that it requires a weekly group for drug education, and also he goes to one-on-ones with a counselor as well, and that team works with the doctor, and that doctor is very proactive about weaning process as an option for a future goal. Um, it's of course case by case, it depends on the person, but they definitely introduce that idea as an option, right? And I feel like I see my peer just flourish, and my peer went from say 2.5 strips down to 1 strip, and it's happening. It's happening. So he will eventually be completely weaned at some point. And I think it's a great program. I highly support it. It's been really successful.
Thank you, Cheryl. Mary Toll, would you like to share your comment with us? You could unmute.
This is a little different, but I'm a mental health peer specialist. And so in my role, I have helped people prepare for doctor appointments or phone calls, and then if they were interested, and then gone to the appointments with them, and then come back and talked about it after. And so that's kind of a lot of a time commitment, but if he was interested, that would be something you could do.
yeah, especially if he's very anxious about it and stuff, it might really help him to sort of stay organized and make sure he gets all his questions answered. Yeah, good idea.
Yeah, thanks, guys. That's some great ideas, Cheryl, Mary. All those sound really great. Thank you.
Okay, so Susie, I'm gonna let you just give us like a quick summary of some of the recommendations for a case presenter. And again, thank you, Brett. Great case. Thank you. Very, very interesting case. Susie, go ahead whenever you're ready. Thank you.
Thank you, Andrea. Yeah, really, really interesting case that just brings up so many real life issues that happen when we're supporting people through different changes. And this one had the complexity of, possible incarceration, challenges with transportation, the wanting to come off the medication, and yet maybe the big fear is that if he has to go to be incarcerated again, then there will be maybe a withdrawal process that he wasn't ready for. So I think all of these resources, it was wonderful to hear from Dr. King and have that expertise here. And the ideas of trying to gather as much information as you can from the people who can answer the questions, the institutions who might be involved, the court systems, and then also the peer recovery aspect of this person seems involved with a recovery process. And to be able to talk to someone else who's had the experience, who can say, yeah, there were moments that were difficult, and here's what I did. And to also explore the pain management issue, that if that's still something to be dealt with, if there's a chronic pain situation happening, to I've known of different groups that are actually chronic pain management for people in recovery, and you can talk about the alternative ways that you can manage pain, whether you're going through a change in medication or you're trying to uh, moderate that or live without it perhaps, but there are some options that people can use. So it sounds like there's a lot of information gathering to be done to really this gentleman seems very fearful and with a lot of complexities in his life with good reason. But I think just answering some of these questions would alleviate a lot of his fear and make whatever comes along more manageable if he's not as frightened. So thank you, Brett, for the case, and Dr. King for your information.
Thank you, Susie, and thank you to all of you for taking part on this conversation. Please remember to answer the post-session survey, and remember you'll receive the material, the great material shared to us by Dr. Deem after the class, and we'll see you all next month. It has been great to see you all. Thank you.